And you all say you have till 11:35?
Yeah.
Yes. I'm not hearing myself. Means to let you know, like, because that's stressing it. You're not muted. But you're
Then the brain goes just comes out. It's like the gun.
you're not muted, just so you
Right. All right to go. You got it.
know.
So trading. And then you don't start them hearing you say, give me people like script. That much you don't great. You know? Okay. So well, this the presentation. Got the Zoom.
That's the second one. Yeah.
You should have a bunch of PowerPoints open. I would do one at a time. So which one? That's the one we're using?
Yeah.
Okay. Please.
That's this.
I'm already figured out the camera can be on the channel.
Taylor, can I have your number just in case I need to? Please. What actually camera? It's telling
413. Right. Turn 0. 48.
And see there.
Well, the other page that just closed it left on the computer. There's a folder on the laptop. Then is it just arrows?
Yep. Go ahead.
Webcam.
It's going.
You can see the panel on.
Yeah, that's here.
You can see the panel on there.
Yes.
Here.
As long as you see them, great.
They're far away, but yes.
Thanks so much.
We'll see the panel.
Yep.
Can you get on the turn that one back up? Okay. It's stable. It's so much better. Yeah. Yeah, something so you in company, it's usually before things fun. It's a big concert. And like just like I did say. All right. Start. Yep. Have a great day. Any more chance? Okay.
All right, welcome to our first session of the Health Equity Summit. I'm Dr. Judy Wells. I am the Director of Social Medicine here at College of Medicine, as well as the Director of International Emergency Medicine and Health Equity for the UVM Health Network. It is a pleasure to be here with you all and to get to moderate a session with such an incredible group of folks. So our first session today is called Being Queer, Using Drugs and Getting Through Life, Caring for Hospitalized Patients with Opioid Use Disorder. And with that, I'm going to turn it over to the team, and Richard Elliott is going to get our introductions going.
Hello, everyone. My name is Richard Elliott. I'm the Health and Wellness Manager at Aspen, Vermont. And I want to let you know that this panel is going to be just about being queer, using drugs, and getting through life, as well as mixed in with some data that we put together from a Health and Wellness 2024 survey that we put out in May that ended around September. I'm going to run off the introductions. Cal, can you go to the next slide, please? So again, my name is Richard Elliott, and pass it off to Megan.
Hi, how are you all today? Good. My name is Megan, initial pronouns. I work with the Pride Center for Vermont, where I'm the trans program health and wellness advocate. I'm sorry, I haven't mentioned that now. But it's such a nice.
Hey everyone, my name is Olivia, and I am a peer support specialist with the Turning Point Center in Burlington. And is that all you want me to say right now?
Yeah, I'm Jason Peacock, case manager at Vermont Cares for HIV case management, and I work with harm reduction. We're going to move on to our first question. So what is something unique to being queer and active drug use that y'all find? Is there anything?
I wouldn't say it's unique, but I would say that drug use in queer populations is much higher and much more accepted. Like certainly and I can't speak as someone in the gay community, but it's sort of generally accepted. Party drugs were definitely much more a thing. I think there's much less stigma between queers about drug use. And I think it's probably more acceptable in queer spaces than necessarily in straight spaces.
So first of all, how much time do we have here? Okay, so I can take a minute. Okay. So I just want to let everyone know that, I was asked to speak here yesterday by my colleague. So I wasn't planning on it, so I didn't think anything through. So I'm seeing this question right now for like the first time. And for me, I just want to identify as like publicly, I've been questioning for years. And the first time I don't have opioid use disorder. I have an experience with substances that seems to be rare. I ended up seeking treatment from more of an emotional, an emotional addiction, it felt like, to psychedelics. And the first time I used these drugs, I was 17, and that's the first time that I even started questioning like what gender meant to me. And so I just wanted to say that even though my substance use became very problematic and led me to seek recovery, at first it sort of helped me think in a different way.
Yeah. So my drug of choice was methamphetamine. I found it at 40 years old. So it was different for me. I guess it was a perfect storm at once. Had an overdose in the family, and my parents died back to back. And I also had a lot of low self-esteem and some issues with my sexuality. That drug seemed to solve all those painful feelings and issues. So 6 years of my life I spent doing meth, breakfast, lunch, and dinner. It was I'd come out when I was 14 years old, so I was professionally gay for most of my life. By the time I turned 40, I don't know, I had a midlife crisis, and why not try meth? And it is a whole another world. It's a subculture that I don't think people really understand unless they've been in it or been touched by it. And it is incredibly kind of accepted in certain that group of people. And it's pretty scary. I got out 2 years ago and came to Vermont, and that's my experience with it.
We can go back to that. So I want to say, kind of jumping off of Jason's point, I'm also a meth addict. I'm also in recovery from meth. And something that is really unique about it is the fact that if no one understands what meth does to people, their inhibitions go out the window. So if you are someone who uses condoms, cares about who you have sex with, our understanding of sexual health practices, that all goes out the window when you're on meth. Like you don't care who you have sex with, you don't care about some HIV status, you don't care what is happening with you. And obviously that leads to complications with your own health, complications with other people's health. And that's something that I have to take account of when in active use and out of active use. I unfortunately acquired HIV due to my meth use, whether that comes from the people I interacted with and or whether that came from me sharing syringes with people. I'm not entirely sure, but I know the fact that being that my inhibitions were lowered, I really didn't care who I was interacting with and what I was doing. So I do feel like that is a unique part about being, it's not specifically for an individual. If you're straight and use meth, but that part is really like unique to the gay world. Gay men continue using meth, you have sex for a length of time, and you necessarily don't care who you have sex with. So that's something like keep in mind when having interaction with people who are
an active use for meth and or recovered from.
I just want to say about this slide, it's worth bearing in mind that when you look at the source of our data, the majority of respondents for this survey, of which we had what, close to 400?
430.
Yeah, identify as woman or assigned female birth. We did not get as much response from the stereotypically assigned male birth gay identifying community. So I think that, rates of meth use are low in this, but I think that this data is skewed a little bit towards the female identifying populations rather than.
So next question is, what were the interactions had with providers when seeking support for care?
Specifically with regards to substance use. I can't really speak to this. I have not sought care for substance related disorders. I've been a substance user for gosh, a long time. And I want to lump into that marijuana, cocaine, psychedelics. Ketamine is a very large drug of choice, specifically in the, I know a lot of trans femme individuals use ketamine, myself included. And I think when you're a queer person living in the world, obviously gender dysphoria is a thing, body dysmorphia is a thing, and these drugs provide an easy way to detach yourself from the reality of your existence, particularly ketamine as a dissociative anesthetic is almost the perfect drug. It allows you to see yourself in a different light, to feel different in your body. So the only way I can speak to my experience in healthcare is as a healthcare provider. I was a paramedic for 17 years in Vermont working in the field. Dealt with a lot of people having a crisis around drug use. And I will say, I came out as queer in 2017, still working on the ambulance at the time. In a particularly rural part of Vermont, and people think drug use is, something confined to cities. The people we see in City Hall Park, everyone likes to bitch about that. But the reality is that drug use is spread across Vermont. You have folks living in abject poverty in a trailer in the backwoods of Orange County who are active users. You have queer folks that live out in the woods in the middle of nowhere. So I think that a lot of the barriers that exist to people seeking care come from their very first point of contact with care, in which case that would me when I'm picking up in the ambulance. And I will say the lack of empathy among my colleagues and peers in the industry was staggering. There's so much stigmatization around being queer to begin with. And then when you mix drug use into that, these people are essentially worthless to a lot of people who work in healthcare because of their own personal judgment or life experience. So I can't talk about the treatment for that, but I can talk about, extending those levels of empathy and care from the first point of contact all the way through the continuum of care to hopefully, if that person desires, some sort of inpatient treatment. So that's my experience.
Sorry. I can speak to that question from personal experience. I have been involved with substance treatment for substance use disorder since 2016. And my sobriety date, I'm sober now. That was my path for recovery. And my sober date is in February 2020. But prior to that date, I was involved with, I think, 5 different treatment centers. And a few of them were IOP programs. Those IOP programs, and what ultimately helped me was residential treatment. But I do remember, so I used to look really a lot different than this. I used to be. Substances helped me feel comfortable in expressing myself. And I used to have a shaved head. I shaved only one eyebrow, and I felt like my providers were scared of me. And I wore clothes that I made, and I wasn't very skilled, so I kind of, I felt like people were scared of me, and they probably were. But I mean, I was scared of myself, and of my use, really. And I feel like the fact that none of my providers seemed to like have lived experience with being queer and questioning. And I feel like that probably has something to do with it. I don't know. You can only learn so much, but I think that part of why people seem to be afraid of me was because they didn't really understand what I was experiencing with substance use and being queer. And I felt because of that, because I felt scared and judged, I was really hesitant to be honest. And yeah, I went in and out of IOP programs for 4 years. And it was really rough. So awesome. Do you want that?
Yeah. You take that. I showed up in Vermont about 2 years ago, for the geographical cure. I'm from Southern Connecticut. That was a start on my journey. The next steps would be pretty easy because I was looking for help, wanted help. I wanted to start a new story. And I had a great experience. I walked into Vermont Cares as a client, and a year later, I'm working there as a case manager. Vermont Cares kind of the case management services are pointing me in the right direction to Sephora and Turning Point. And I had a good experience. And when I walked in the Turning Point, I met someone named Emily who referred me to this IOP in downtown Burlington called the River Rock Treatment Center. And it was a whole body approach. It was mind, body, and soul. It wasn't just, sitting down in groups. We had acupuncture and meditation. It really addressed all the things I was afraid to unpack and gave me the tools to do this life I'm doing now. So it worked out really well for me. But the thing to keep in mind is we can open doors for people. They have to walk through it themselves, which is hard. When I first started case managing, I had some attachments to the outcomes of clients, and you have to realize, it's up to the person, the individual, to decide to change their story and to walk through that door. What we can do as providers is have that door open and hope that something in their lives brings them to a point where they want a life they can be proud of again. And that's my story. And it's pretty amazing. I think lived experience is huge. The only people that really I felt comfortable taking advice from was the people like Olivia and Emily and people who lived my life or that walked in my shoes to some extent.
Before I say what I'm about to say, is anyone here works for Valley Vista? Yeah, so in Burlington, we have a few options for resources to folks actually resource seeking help outside of Burlington. I think the picture is much more dire, and as someone who has visited Valley Vista as a healthcare provider on probably hundreds of occasions, I don't think that's we don't have great options outside of our. I think that's one of them. We do treatment facilities statewide, besides what we have locally in Burlington. And I wouldn't wish that on anybody. I don't know how anyone is getting help. It feels like jail, both physically and emotionally. Even me just walking in the door, I can't wait to get this patient out of here. And I think we need to look really long, hard look at what resources we have in the state and advocate for more spending on recovery, because it is just woefully inadequate. I don't know who y'all are referring people to outside of Burlington, if you work outside of Burlington, but I don't think we have any good options, honestly. That's my first opinion. Sorry if you work at Valley Vista.
That note, the back to previous slide, to that note, having adequate childcare, having adequate treatment options are as possible. I'll speak on my story. until I had a crisis moment here in Vermont, even when in active use and or had active use, I was afraid to even think of calling someone because I know that as soon as I walk in the door at say a hospital or treatment center, the first thing they're gonna think is, oh, another one's coming here. We have to deal with that. Not work with, deal with it. And that's something that sticks with me because my use has come from Jersey, my use is now here in the state of Vermont. And I see similarities between a rural state like Vermont and a metropolitan state like New Jersey. The care is essentially the same. A person who is using drugs, a person who is having mental health issues coming to the door, and no one even receives care that much. They care a little bit. They care just enough to get the person in treatment. They care just enough to get the person out of the door. But they don't care to a point where they really want to understand what's going on with the person. If I was having a mental health crisis, the first thing the person would assume is that if they see my file, the first thing that they would assume is that they are high. They don't even take into account that I may be going through psychosis. I may be having a mental break. I may be having an episode. It's always the drugs come first. But that's something also to keep in mind is that there's a duality with someone who is having an issue with substance use and an issue with mental health issues. So which are you going to address first? So I just wanted to point that out. The last question is, what efforts can be done to elevate care and support for those in active use for seeking?
Well, asked and answered. Yeah, more money, more resources. And again, I think a lot has to be done to destigmatize substance use, particularly in queer communities. I think if you're a cisgender, straight, white man, seeking care for substance use, your experience and the resources you might have at your disposal, particularly if you are, middle class, middle income American, will be vastly different than if you're, a queer person of color seeking help for the same things or using a stigmatized substance. And by which I mean, if we watch TV, like, stock traders using cocaine, it's like, yeah, it's the boys. But, queer people using meth, that's a whole different thing. So we stigmatize that substance. It's no different. Like, what's the difference between a college student taking Adderall to stay alert for cramming for a test versus methamphetamine? It's just a couple of molecules different. It's the same damn stuff, but we stigmatize it. And a lot of that stigmatization is based on class and race in this country. Our poorer populations can't afford bougie drugs, so they still have the same damn problems. So the drug they end up using is meth, it's highly addictive. And destroys a lot of lives. And those people are already written off by society. So when it comes to giving them help, like, again, way less resources, way more stigma, and generally, people just don't care. Like in white Vermont, if Richard lives somewhere in rural Vermont, calls for help or ambulance, you get a couple white guys show up, already judge him for being gay. And they're gonna be like, yeah, and like his color, basically gonna make him work with the skill of these people. And I'm sorry, that's fucked up. So we need to change attitudes, both internally within our own profession, public sentiment, like, I don't care if you're a cocaine user, or a meth user, or a ketamine user, or someone that drinks 10 cups of caffeine a day. It's all the same to me. Like, if you have a problem with your use of your substances and you seek help, you should be treated equally. And we need to put the money towards fixing this problem, like all the other problems we have. And I think, whether we need to put that back on different initiatives, so we're just getting a free pass. We already see the tobacco companies, we see the alcohol companies too, because that destroys lives, puts people in hospital and funds our healthcare system billions of dollars a year. Okay, we need to just stop looking at drugs as, a problem we can legislate away and, incarcerate away. We need to do this by investing in our healthcare system, our social supports for folks, and just our attitudes in general. Come on.
You just go back and just say.
Yes.
So I have two ideas. One is not an immediate thing that anyone can do probably, but my vision is it would be one thing that would be really helpful would be so for me, sober living really helped me so much. I lived in a sober house for 13 months after I left treatment, and I was in an all-girls home. But I know a lot of people who are trans and don't feel comfortable in a house with people who identify as a man or a woman. It's all separated. It's like either you're in a man's house or a woman's house. And so one thing that would be really nice to see would be sober living facilities that are queer for people who are in our communities. Yeah. But that takes, that's not something we can do immediately. And neither are, we need more treatment centers, we need more options, like we need more housing options, like transitional housing. But that's like an overwhelming thing to think about, and who am I? I'm a peer support, specialist. Like I'm not an expert in planning and finances and this type of thing, but what I don't feel like an expert in this, but I do feel like I have something to say about like social changes that could happen like immediately. I think that two things. One thing that would be helpful would be for providers and to become more educated or understanding in like what addiction even is. Because I feel like a lot of the providers I saw were like, why are you doing this? Like, what are you doing? I legitimately like could not stop. Like it's maddening, it's confusing. Like I don't really know how to explain it. I just remember for the last 2 years of my use, I kept saying to my mom, like, I need to get locked up. I need to be locked up. Like, I need to go to a treatment center and I trust myself. Like, every day is the same thing. Go to bed saying I have to get sober. And I wake up the next day and all I can think about is using. It's like, so there's that. There's understanding, like, that the person using, if they're identify as an addict, like I did, like, it's not like a moral problem, you know? But another thing I think would be nice is, the treatment center I went to was called Green Mountain Treatment Center in New Hampshire, and there's a someone who works there, and his title was a spiritual director. That was my favorite person there. And this is quick, I'll be done. So, because we have 5 minutes of studies, it's fine. So he has this theory, and I encourage everyone to look into it. It is called the dislocation theory. And it's basically suggesting that drug use or drug abuse is a symptom of our community. So I would like to see, conversations between people who are in active use, people who are professionals, people who are, just regular people, instead of like these divisions between everyone, especially the people who are in active use. I don't know if that makes sense, but thanks for the presentation.
So my firm belief, for everyone who's a caregiver and provider, when somebody walks into your office, walks into your clinic, lead with kindness. It goes a long way. And listen to people's stories. Sorry, I'm bringing you right here, but I walked into her office. She walked into the exam room, and she was truly, I believe, interested in what my story was, what brought me here. That helped me be really comfortable with her, and that's a huge piece of this puzzle: is having people feel comfortable enough to tell you some really hard things. And if they can do that, they can take the steps into recovery. But lead with kindness. It sounds, cliche, but it is what I do every day in my life.
And pass it on. I guess. Thank you, everyone. Thank you for joining us. Um, um, to the last question, I was speaking on it. One thing that everyone can do can listen. Can actually have a time here. You can try to understand what your participants and your patients are talking about. It may sound like randoms, it may sound like ranting, it may sound like they're just having conversations about nothing, but there are grains of truth in what they're saying. So honestly, just take it here, ask deeper questions like, what do you mean by that? Why are you saying that? Where's this coming from? Questions like that really do help providers and help you understand where this person's coming from because once again, it may sound like they're just coming out of nowhere things they're saying, but it's coming from a place of truth. So once again, what you can do, listen, it's that easy. Once again, thank you everyone. Thank you for joining us for this panel. I really appreciate it. If you want to give another round of applause, I would.
Again, to our panelists, to Richard, to Megan, to Olivia, Jason, Kale, one of the things I'm hopeful is that hearing stories, connecting stories to the real lived experiences of humanity will really change what we see in society. So thank you for your vulnerability. Thank you for sharing with us, for being so open and honest. We're so appreciative. We're going to take questions, but at the end. So we're going to do the next session. And then after this next session, we're going to have hopefully about 15 minutes or so for Q&A with all the panelists. And we'll bring up Dr. Ellie Reiser for our next presentation. It's not quiet, isn't it? There's a bit of a it's just so. So, it's checked. Thank you. Yours. Thanks so much.
Everybody hear me okay? All right. I just want to say big thank you to the panelists who came before me. I think it's absolutely critical to have people with lived experience at the center of the conversation for healthcare, for people who use drugs, for policy. So it was great to hear from you all. A little bit about me. My name is Ellie. I have been working in some form of addiction care since about 2002. I'm now a physician. I practice hospital medicine and addiction medicine at UVM Medical Center. And this isn't meant to be too super formal. So if someone has a question or a comment, just raise your hand, do this casually. Advance. Great, there we go. I don't have any conflicts of interest. Some objectives today, we're going to talk about some health inequities among people who have opioid use disorder in particular, talk about treatments and how they've changed in this new era we're in where the illicit drug supply is primarily high potency synthetic opioids like fentanyl. So it's changed the landscape for the patients I take care of, and talk about ways to reduce mortality for people who use opioids. And I cannot have a talk without at least acknowledging and prefacing things by speaking on the war on drugs. So in 1971, Richard Nixon declared this war on drugs, and it's turned out to be a real catastrophe that continues to go on to this day. So we know that people of all races use and sell drugs at similar rates. However, arrests are seen more often in people who are Black, Latinx, Indigenous, those with low income. We incarcerate Black people disproportionately. And the reason I bring this up is that drug policy is public health policy, and you can't like unentangle medical care from our drug policies and how we police people who use drugs and sell drugs. And I think all of us are probably familiar with charts like these. But it's just to say our war on drugs has not had an effect on a positive effect on overdose deaths and on the health of our communities. So over the recent years, most of the deaths we're seeing from overdose involve synthetic opioids like fentanyl. Deaths are often polysubstance use, so people have a lot of different drugs in their toxicology. And stimulants are also becoming more represented in overdose deaths. So we've lost over 1 million people since 1999. I've lost many friends, including my friend Sabrina Goodman. She was 23 years old when she died. I'm sharing this information with the permission of her family, but she was a vivacious, intelligent, creative young woman. She also had opioid use disorder, and she did not have access to care to reduce her mortality and reduce her risk of dying. That's so much what we're talking about today, right? Like, how do we get people access to proven ways to keep them alive and keep them safe? So Sabrina is one of the many reasons I kind of harp on this. I'm always talking about this. But it's so important that as a healthcare system, we give people easy access without stipulations to evidence-based practices, right? So we know that opioid use disorder is treatable and overdose is preventable. Here in the US, there are only 3 meds that are FDA approved to treat opioid use disorder. So if you know about these, you're well ahead of the game. In other countries, there are other evidence-based medications, but these are the 3 we have here. So methadone, it's been around forever. It's like the OG, it's been around since like 1971 or so. I'm going to go deep on the pharmacology here because I think it really matters, but it is a little nerdy. And if you aren't like directly a clinician, take it with a grain of salt. But methadone is a full agonist, meaning when it goes and binds the opioid receptor in the central nervous system, it activates that receptor fully. That's things like, if you've ever had pain meds when you have your wisdom teeth out or something, analgesia. That's what all opioids do. It can cause constipation, pupillary constriction. There's a whole kind of potpourri of side effects from opioids, and at higher doses can cause respiratory depression and death. It has a fairly strong affinity for the receptor. Affinity just means how tightly it binds to the receptor. And that's really important when we select medications to treat opioid use disorder. The reason being, people return to use sometimes. They may be on methadone and they may inject some fentanyl. And we want those people to be as safe as possible if that happens. And if you have most of your receptors in your brain occupied by methadone, that fentanyl is going to need to bind competitively and kick that methadone off the receptors to do its job. So that is one of the ways these medications are protective. So all the meds we use to treat opioid use disorder bind that receptor really, really tight, and that is one of the ways it's protective. Buprenorphine, likewise, it's a newer drug compared to methadone. It's been around since the early 2000s. It comes in like a zillion different formulations and brand names. They're all partial agonists. So buprenorphine, it's kind of a cool pharmacology. It's the only partial agonist I use regularly in my practice. And what that means is it also binds very tightly to the receptor, but it only partially activates it. And that gives it a really unique and favorable safety profile for patients. And I'm not going to talk too much about naltrexone because it doesn't have a mortality benefit that we see in the other 2 drugs. It's an antagonist, binds tight to the receptor, blocks it. So if you put other opioids in the system, they will not have much of an effect, if any at all. The problem is that you have to get someone totally like having no tolerance totally through the withdrawal period in order to initiate naltrexone. That's really hard for people. That can take several weeks. And if someone does not take their naltrexone, they have no tolerance, and that's a very, very vulnerable spot for people to be in if they return to use. These meds, it's rare in medicine that we have medications that have a big impact on mortality. And when we do, we try to use them. So for example, I really think these are comparable to insulin for diabetes or, heart failure medications that improve mortality. These have a significant effect. So methadone and buprenorphine, so people with active opioid use disorder die at about 6 times the rate of the general population, but you can decrease this fourfold by being on one of these medications. So I really think they aren't the only treatment. I'm not saying that. What I'm saying is that they're the gold standard because of their efficacy. And, I think for many years, I've slowly over years changed my view of what successful treatment is. And, I think early on, I thought really abstinence was the primary only goal. And I've since changed my mind quite a bit. I think abstinence is great. If that's what your patient wants, they're aspiring to that. I absolutely support that. It's so important and perhaps the safest thing, but it's not always realistic. So medications are a very important tool, as I mentioned. Maintaining tolerance. What do I mean by that? Tolerance is protective. So that is when someone takes a certain dose of opioid, it's going to have a certain effect. If they stop taking it for a while, they may go through withdrawal, their tolerance goes down. That same dose that they did fine with before could kill them, right? So maintaining tolerance is so important if you have a patient in front of you who is going to continue using. And there are several ways we can do that. We want to reduce overdose risk. Maintaining tolerance is one of those ways. We want to retain people in treatment, and I don't just mean treatment for substance use disorder, yes, but also co-occurring mental health disorders and just medical care in general. We want people to have access to sterile works. We want people to ideally reduce the highest risk ways to use drugs. So if I have a patient who is, say, injecting drugs into their jugular vein in their neck, but I can get them to transition to smoking or some other way that gets them high also, but keeps them safer, perhaps that is a step towards success. Mutual support groups are key for many people. We minimize the euphoric effect of drugs, and that's what some of these, methadone and buprenorphine can do. It reduces the reinforcing effects of intermittent drug use and decrease the risk of infectious disease acquisition and transmission. So in particular HIV and Hep C, but many other infectious diseases, and of course, improve quality of life. But we know there's a lot of stigma, particularly in the medical community, toward people who use drugs and those with use disorders. This is an old study, but I still think it's worth quoting. It's from the World Health Organization. They looked across the world at 18 medical conditions, and they found by and large that substance use disorder was the most stigmatized. And I don't think we need data points to show this, but certainly stigma leads to patients being less likely to seek treatment, lower self-esteem, and worse prognosis. I certainly seen this in the hospital very frequently, but my patients with substance use disorder leave as self-directed discharges much more frequently than patients that do not have substance use disorder. This is multifactorial, but I think some big reasons are because pain is inadequately controlled, withdrawal is not addressed, and they feel stigma from the healthcare team. And in primary care as well, this was a recent survey published in the Annals. They looked at, I think, 500 primary care physicians and asked them about treating patients with opioid use disorder, and a majority were not interested. And that's probably for a lot of reasons. One being there's a lack of education amongst clinicians on how to address opioid use disorder. There may be fear and there's certainly a stigma. Nonetheless, opioid use disorder is very prevalent in Vermont as well. It's no exception. About 20 people are estimated to have this disorder. About half of them receive medication for it. The third bullet point is recent data out of our emergency room at our hospital. Almost 5% of all comers to the emergency department screen positive for OUD. So it's just prevalent. This is an overrepresented disorder in the acute care setting. And if you look at all substance use disorders, it's really common that we're admitting people to the hospital where drug use, alcohol use, tobacco use has in some way contributed either directly or indirectly to what's going on with them and their reason for hospitalization. In Vermont, we have the hub and spoke model. Have people heard of that? I'm seeing yes. Okay, so I won't go into it too much, but one of our family medicine physicians, addiction med docs here, Dr. Bookman, sort of helped develop this idea in Vermont, and now it's used in other places in the country too. It's kind of cool. The hubs are opioid treatment programs. Kind of the other term is methadone clinics. So they have subspecialty care in addiction medicine. And can provide support to typically primary care clinicians out in the community that are prescribing buprenorphine for people who have OUD. So there's some back and forth between hub and spokes and support, like medical support for the clinicians. Nonetheless, despite our innovations, people are really dying. People are hurting, people are overdosing. So 236 opioid-related overdose deaths here last year. And to understand why this is happening, it's for many reasons, but I think one of the big reasons is that the illicit drug supply is complete trash. People don't know what they're getting, and they can't control dose very easily or what substance they're putting in their body because they just might not know. So these are data out of southern Vermont along the I-91 corridor. These are 100 or so bags of opioid something or other that were picked up, I think, primarily by police, and then they ran them through a mass spectrometer and figured out what was in there. And so of all these bags of dope, you see about 90% contain fentanyl. And I'll tell you what is not in a bag of heroin. So about 4 of the 101 samples had heroin. There are a bunch of acronyms and stuff I've never heard of before. Those are all just analogs of fentanyl. So they're all kind of analogs. You switch out a side chain, get something else, perhaps more potent than fentanyl. Xylazine, you probably heard of in the news, or perhaps know people that are using it. It's an alpha agonist. Originally, we tried to develop it as a blood pressure medication, but we realized it was really zonking people and making people super sedated, so it never really came to market. But it's used as a large mammal tranquilizer in veterinary medicine, and it's pretty prolific in the drug supply. So over 60% of the samples in this group had xylazine in it, cocaine, nitazines. Anyone heard of that? I had to look it up when I first put together this talk. So nitazines are another type of synthetic opioid, illicitly manufactured, more potent than fentanyl, just what we need, something more potent. And in a minority of the bags. However, I think it just illustrates that the drug supply changes really quickly, and medicine and science is having a hard time keeping up. We like a good randomized controlled trial to tell us what the best thing is to do. And by the time we do that, we're on to a whole new type of thing going on with the drug supply. So fentanyl, high potency synthetic opioid, about 100 times more potent than morphine. It binds quite tightly to the receptor. Talked about why that's important. And we use it in medicine all the time. It's a great analgesic, fast on, fast off. The pain control effect lasts about an hour. The thing is, with chronic use, with illicit use, over time, it's lipophilic. So it's stored in adipose tissue in fat. And for people who are using multiple times a day over weeks and months and years, They just have sort of a large amount of fentanyl in their body that takes a while to leave their body. There are even studies showing that takes, on average 7 days or more for people's urine to clear of fentanyl after their last use. So it's sticking around for a while, and it's making it more challenging for us to get people on methadone or buprenorphine. People's tolerance are much, much higher than what we're used to seeing, and the withdrawal is just really ugly. I think, so this is a busy slide, but what I want you to look at are the little red bubbles at the bottom. This is from the Philadelphia Public Health Department. They do an incredible job of tracking their drug supply and describing it for people. So they came up with this potency index where they have this thing called the potency factor. It's basically just a mathematical way to say, okay, the potency of fentanyl is equal to 1. And therefore, the potency of heroin would be about 0.02. Carfentanil, for example, would be 100. And so in that way, they can sort of standardize or describe how potent a bag of dope is. So these are 4 random samples off the street in Philadelphia, I think a couple of years ago. You'll see in sample D, it's all cut and 1% carfentanil, yet it's literally orders of magnitude more potent than sample C that's 50% heroin. So that just illustrates why our patients are dying. Like, they don't know what they're getting, they don't know the purity as in what's in it, and they don't know how potent or strong it is in the vast majority of cases. So this all boils down to the work I do. I work in an inpatient setting, and I'm always sort of preaching, sometimes to the choir, but preaching about how important it is to at least offer patients methadone and buprenorphine. It's up to the patient whether they want to take it or not, but we're missing a real opportunity to connect with patients and help them reduce the risk of dying. So often the patients I'm seeing are underinsured. They may not have a primary care physician. They're acutely ill. And this is a real opportunity to offer them help. We know that starting these medications decrease illicit use on discharge, lowers readmission rates, and everybody's just going to have a better time. If you have a patient who's in acute pain, who's scared because they're really sick in the hospital, who's withdrawing, they're going to have a terrible time. The whole medical team's going to have a terrible time, but we can ease that by treating their withdrawal and their substance use disorder. But we do a horrible job at this. This top bullet point is from a study of over 10,000 patients across over 100 VA hospitals, patients with OUD who are not on meds when they came in, and they found that 2% were started on methadone or buprenorphine at discharge. Perhaps our most vulnerable population, those who do survive overdose and are seen in an ED or admitted to the hospital, less than 1/3 are started on one of these medications at 1 year. And even among our subspecialty kind of addiction treatment centers, a majority, 2 out of 3, don't even offer any of these medications. Like, the gold standard is not offered at our specialty care centers. That's a problem. So what does this leave us in the hospital? Medically supervised withdrawal, sometimes colloquially called detox. And the problem with detox is I usually don't offer it to patients unless they explicitly ask for it. I will not force this on a patient who does not want this. That's the wrong way to go. Because 90% will return to drug use soon after discharge, and they're at a vulnerable increased risk of overdose during that time. So if I were to grade how we do things in the hospital, I would give us an F. In the interest of time, I'm going to skip this, but choosing a medication, it all boils down to, what does your patient want to do? What works for them? If you're going to start them on methadone, that looks like going to the clinic every day between 6 a.m. and 11 a.m. If you miss a dose, there can be consequences to that. And I don't know about you all, but if I had to go pick up a life-saving medication every morning at 6 a.m., I don't know I could do that. I'd have a hard time, and our patients can have a hard time with that too. Buprenorphine, it's kind of cool. It's a partial agonist, and I told you it has sort of a favorable safety profile. And that's because, so if you look at this chart here along the bottom, you see dose. Along the other side, you see the effect of the new opioid receptor. And so with full opioid agonists like fentanyl or heroin or what have you, with increasing dose, you can reach 100% effect. So that's with analgesia, sedation, and overdose. With buprenorphine, even at super high doses, you reach this plateau phase, sometimes referred to as the ceiling effect. And there's just not much respiratory depression. There's less psychomotor and cognitive effects. So in that way, it's hard, particularly in someone with tolerance, to overdose them on buprenorphine. One of the issues I mentioned is in this fentanyl era, the way we start these medications has by necessity had to change a little bit because people are having a more difficult time getting started on buprenorphine. So this is sort of the traditional way where you'd have people abstain from opioids until they go into a little bit of withdrawal. Then you give them a test dose, make sure it goes okay, and redose that till they feel better. But the thing you want to avoid, kind of the most feared thing, is precipitated withdrawal. So if I'm a person, I'm injecting fentanyl, I'm feeling euphoric, I'm up high on the curve, and I take a bunch of buprenorphine, what happens in effect is that I drop from way high on the curve to down here, and that feels like that is opioid withdrawal. And this can be really pronounced and severe. That's called precipitated withdrawal when that happens. So the way that you fix this is a little tincture of time. Give it some time, have your patient go into withdrawal, and then you give them the bupe, bump them up in the curve, and they feel a little bit better. So that's a big fear. It's actually pretty rare. So less than 1% of people, like in a controlled emergency department setting, showed signs of precipitated withdrawal. But it's really bad. 1% is probably more than what we want it to be, 0%. And there are other strategies to try to avoid this. So high dose buprenorphine is something that's used. Low dose buprenorphine, whereby you can continue full opioid agonists, is helpful for me in the hospital and my patients, because often my patients have acute pain and need analgesics, and I can continue those while slowly introducing itty bitty tiny baby doses of buprenorphine till the brain is saturated. This is what our protocol looks like at UVM. And then there's methadone. So I would wager that many of my colleagues feel this way like I used to. And the reason is that methadone is weird pharmacologically. It's tricky to initiate. The metabolism is way unpredictable. So you could metabolize it in 8 hours and you could take 59 hours to metabolize it. The peak concentration is delayed after you take it. And that squiggly red line, that's when you give a patient a set dose, and over time, their serum level will increase. So what works for them on day 1 might cause oversedation on day 5. So this is the thing we fear. And people just aren't very practiced with initiating these medications. And there's no great evidence base to how we start these. So it's all expert opinion, which has fluctuated over time, is different across different countries. And it boils down to that the dosing needs to be individualized to the patient in front of you, to their tolerance and to their response and their unique metabolism. It's highly regulated, not as much in the inpatient setting. And then the last point I want to leave with, which is perhaps the most important, is that harm reduction is really critical. So I see this certainly in my patients, that there's a good proportion of patients who have substance use disorder that don't feel ready or do not want to stop using, and that is okay. There are still things I can do as a physician to try to help them be safer, have a better quality of life. So some of those things include safer drug use practices, of which there are many, and critically, access to syringe service programs. They do not perpetuate drug use. These are data from the CDC. People who have access to sterile syringes in these services are 5 times more likely to enter treatment, 3 times more likely to stop using drugs. Those are big, impressive numbers. So I want to make sure my patients know where to access sterile works, and naloxone, of course, an essential tool in the community. 80% of overdose reversals are actually carried out by people who use drugs. Our patients have expertise. They've done this before. They need meds in their hands to be able to control this. So I love this poster that used to be hanging up at our Safe Recovery downtown, our syringe service program. It's not there anymore. I took this picture when I was an intern, but these are all overdoses, lives that were saved by their participants, hundreds, right? So super critical. So my takeaways for you are that all patients with active opioid use disorder at a minimum should be offered methadone or buprenorphine while they're in the hospital, even if they're there for a different reason. We need to respect the tolerance because it's protective and that harm reduction saves lives. With that, I'll be done.
There's a different model of how methadone is dispensed. For research about that, like I worked in one of the clinics and it just felt like we're just contributing to stigma. You know, it was like an outpost location, a lot of stuff going on in the parking lot, staff were traumatized. And I was like, wow, are we really making anything different happen? So I'm just curious, like, you know, is there another way that it could be?
Yes, like, that's probably like a whole nother talk, but yes, I think there's a lot of things we could do to improve our rules and regulations around methadone treatment. I think like the laws actually hadn't even changed in like 50 years, and only back in April of this year had we had the most recent kind of small changes that allowed for more liberal dosing on day one. Given all our patients tend to have really high tolerance, so like some minor changes have happened recently, but there's a long way to go.
I just want to say thank you so much to Dr. Reiser. You know, I think one thing that's very evident in your talk is that you're really leading in this area from compassion and empathy and really trying to create an opportunity for our medical community to understand how to treat folks with substance use disorder in a more empathetic and compassionate way. And you truly have really been leading some of these initiatives for our network, for our community, at our hospital. Really appreciate that. So with that, I would love to open it up to the audience for questions to our panel. We do have about 15 minutes. So anything that you're thinking, anything you're feeling, let's bring it forward.
I'm supposed to I really resonated by you giving us a big letter and I feel that all the time and really appreciate you saying it out loud. And you also said that your views of how you define success changed over time in your work. And how have you been successful in getting that to change in people at the hospital, all types of providers? Like to change what is successful in the patient that's coming.
And so for Zoom, you probably can't hear the question. So basically, how have things really changed over time? What have we been able to see move forward?
Well, I'm not sure I've changed things as much or as quickly as I would like. But I just talk about this all the time and I try to do it in a non-judgmental way. I do think people are trying to help, but perhaps they haven't had the exposure or education that they need to do this effectively, to treat substance use effectively. I know in my medical school training, there wasn't a lot on addiction care or harm reduction. And so I think it's only recently, and perhaps the younger generation have a bit more hope for them because they have a lot of interest in this. I've noticed like the Martin College of Medicine students are really into it. They want to know about harm reduction. There's a harm reduction student interest group. So I have hope for the younger generation. For us who are a bit older and have been doing this for a little while, I think, you know, just talking about it, showing them examples of what works. And I think when people start putting some of these, you know, efforts into practice, they start seeing it's a lot easier to provide care, more fulfilling. Their patients are having a better time. So yeah, I don't know. I've changed things that much yet.
I think it's held his hand in his hand.
Okay. At the risk of the question that's sort of a comment, which I have never done. I really appreciated you all getting up here because I think, you know, I'm from the Vermont Food Bank, you know, the stigma that we bring to our work in feeding people, you know, we represent the population, it's the same stigma that physicians or nurses are bringing with them. And I think the point that you said about, you know, seeing it as a moral failing really stuck with me. And then the point about abstinence as not the gold standard. And just to bring it back to this morning, I was thinking about all of these characteristics of white supremacy that are just in our bodies, because here we are in the United States, like this idea of perfectionism, like we're not absolutely perfect, we're failing, this binary thinking. And then I think a right to comfort for all of us who are in these environments where it actually is very uncomfortable to see the humanity in people who are suffering. It's no wonder 4 out of 5 physicians would rather not deal with this issue because it's so hard. And something I've been really challenging myself to think about is not just to work on this as an individual, but to think about where do I have power in the system to change the system. And so that was the way too long comment that but the actual question. I do think about stuff as people, and I have a much harder time thinking about where are the interventions in the system where we can push. And I'm just wondering if any of you have any insights there. Where can we put our energy beyond just opening up our own thinking?
So I am seeing active transcription, so I think it is picking up what the crowd is saying.
That's a big, long question. This is a really complex issue. People like to make it like, oh, it's so simple. Start using drugs, get a job, find a house, right? Like, oh yeah, sure, I could do that. I mean, one of the things I witnessed in a very long time spent in the field, working with folks in crisis in rural Vermont, is like we all think that this is not us. This is someone else's problem. You know, this would never happen to me. Like I'm an upstanding normal person, right? Like we don't realize how close we are to the edge. And I think there's this like empathy disconnect. Like we see these people as less than other, like they're not like us. Like I see so many comments on Reddit about folks in the city of Burlington who are using. And there's just such a lack of compassion for people as other human beings. And I don't know what we can do to change that. To answer your question about what system pieces we can change, but I think we need to recognize that our social supports and the systems that are set up only really work for folks when they've already fallen off the edge of that cliff. Like we don't help people before they get to that point, like when they're really struggling, whether it's with mental health, substance use, poverty, food insecurity, housing. Like it's been shown time and time again, like an investment in folks, like the universal basic income studies that they've been done showing that like one-time payments have long-reaching and long-lasting positive effects on someone's housing, food, employment. But we just choose not to do them. Instead, we put band-aids on things. So I think we need to start looking at long-term investment in people instead of short-term band-aid hits.
Change the entire system, so the entire system out there. In other words, like, I think, but necessarily can't do that, but that's sort of like a individual level. I'll hard back on the aspects of to patients versus to people coming through the door because they really know what's going on. They know what's going on with them. They know what's going on within their circles, within that particular community. I've been doing HIV and SE testing at Safe Recovery for the past year, and just hearing, I always ask them what's going on, what's happening, out there that I can't see, that we can't see. And hearing some of the stories that they tell me, it's like, one, y'all may not want to hear this, but they don't like UVM, they don't like the hospital. And anytime that a professional work judged, they immediately close themselves off and don't want to listen to the participant, the patient. And that's really hard for people to understand that when you're getting told that you're not doing your job, you get defensive. Even though you don't think you're getting defensive, you're getting defensive. Of course, you want to hear highlights of what you're doing. You want to hear and get praise that you're doing great. But once an individual says, hey, this is what you're not doing, you do this instead, you become closed off. And I would think, and I would probably 100% be right in hearing and saying that if you hear that you're not doing your job from an active drug user, you're going to feel some type of way about it. And the fact that that's something I constantly hear is that the people at UVM, the professionals at UVM, the providers at UVM, they're not assisting me in the way that I feel like I should be assisted.
it's a reason why they don't come to the hospital, it's a reason why they don't seek help, it's a reason why they don't go to healthcare system, because no one is helping them, they want to be helping them the way they want to be helped. So once again, it really starts at a individual level. Have that conversation with the patient, have that conversation with the participant, see where you can put yourself, see where you can assist them, see where you can do something. So once again, 30 times it's about, since we can't do that, start with yourself.
I just want to say that where I work at Turning Point, we have people who do outreach. And I think that you're talking about feeding Chittenden. Is that the location you're talking about?
Vermont Food Bank and statewide, but Feeding Chittenden is one of our network partners.
Okay, so I think that maybe a closer relationship between like community partners, like, and maybe we could be more in contact. Because our outreach coaches do go to different locations outside of Turning Point. So, like I go press center. Someone else goes to food shelf and day station. So that's an option also. I think that that's relevant to what you asked.
Addition to this. So what can we do before people end up in addiction? This idea I have, the kind of curriculum that I went through with MIILP, kind of maybe looking at 4 agreements and maybe working that sort of idea into early childhood education. So when people like all of us end up in a part of our lives we don't know how to handle, we can't process, but we drank in high school, so we're going to pick up something that's going to block that out. And we end up in addiction. I think that this is pie in the sky kind of thing, but maybe absolutely looking at like the beginning of people's lives, giving them the tools to handle life when they get to these giant obstacles. Huge. Obviously, it's a perfect world, but I think starting the conversation about that would be best.
So we do have about 5 more minutes. I think there was another question.
That was me. I'm trying to regain my trail of thought. We're so connected in our thoughts and questions. So we're all at a smaller or larger scale part of patients' care and impact, right? So here we are making efforts. We are trying to gain that respect and understanding and support. We're new nurses here. And what can we do to prevent point in this state, a smaller hospital? How can we connect so we can bring that education in ourselves, in our workplace, stay in touch where things are, stay connected so we can help you, understand you, and bring that education forward to those that are coming. How can we make that possible? Because we're meeting once a year, maybe, for lucky. So let's get started. I think we can work together.
Absolutely agree with that. I mean, all of us sitting in a room coming from different parts of the storyline. Let's do this more often. Make a plan to get together with people in active addiction and recovery, and on the end of care. And sit in a room like this, ask these questions, really get to know each other on both ends, and see where everybody's coming from. We might come up with some solutions as a community. We can have them. Great.
Thank you for becoming nurses. I would say, as someone who has been in lots of rural Vermont hospitals and smaller hospitals with folks, and particularly in my role in the emergency department, one of the things you can do is to advocate, be an ally. And I say that because there are lots of folks, well-intentioned, working in small ERs around Vermont, who come to work with just so many biases, and they take those out on their patients. And for younger generation coming into nursing, one of the strongest things you can do is to speak up and to be an advocate for people in active use, for users, for queer people. And if you hear your colleague say something dehumanizing or make a comment about that patient, it's hard. It's really hard to be the one to stand up and speak up. But that's definitely something you can do. And you can let your patient know, I see you as a human. like I'm here to advocate for you, and I'm an ally to you. So it's hard, but it's also easy at the same time.
More on the back end side, a lot of us do have training, and a lot of us do have training how to be liaisons and be educators, trainers for individuals like yourselves who are seeking to better your understanding, better your education with anything around harm reduction, anything around substance use. So you can always touch base, but you can have a conversation with us after this panel, after this, and really check on with us to see how we can continue to work going forward. We have class in the mind connecting with you, coming into your practice, coming into your organization and saying, hey, what can you do to start that conversation with yourself, with your team, with your entire staff? We really do want to see what we can do to ensure that you're going forward with the best practices in mind and with the best intentions in mind. And so have a conversation with us if you don't mind talking to you about it. I could go on and on and on about the subject. So thank you.
So I think a practical thing we could do is take advantage of the fact that we're in a health network. Most of the hospitals in Vermont are in the health network. We floated around the idea before of forming a task force for addiction care across the network, so we aren't all reinventing sort of similar things at each of our hospitals. It would like streamline our effort. I think part of that should be, it needs to be multidisciplinary. It needs to include people who have lived experience, who are potentially patients. I think one of the challenges is that we're in somewhat of a financial crisis across the health network, and there's not robust funding for addiction care. So there is no division of addiction psychiatry or addiction medicine at ABMMC. Most of it is done out of people's personal passion for it and out of grant work. So I just put that out there, but it takes effort outside of your clinical time, really.
I would just say to you, and we are having, this isn't a plug for our session, but there is a session this afternoon on getting involved in advocacy, legislative advocacy. Your voices matter. The voices from the community matter. And so really connecting with the community before you drive any initiative. Also really focusing on, if you're going to call the community in to teach you, compensate them for time. And really make that a sustainable part of your program going forward. And so whether you're part of the network or you're at a more rural hospital, if you're going to bring that education in, compensate these folks for their time and their experience, because they deserve it. We need to change those systems that have continued to oppress folks with regards to how we're asking them to labor for us. And so I think, again, just really want to point back to all of you and really creating an opportunity for humanity in this space. Really, hopefully helping all of us here and those online understanding that substance use disorder has a face, has a name, has a lived experience, has a family, and is special to someone, and trying to create that space for us to really connect on the human level, to change these systems that have continued to fail folks. And so we really appreciate all of your work in this space. So thank you so much. Team, we'll get you on the lunch. And then just make sure you're checking the schedule. Please come up and chat with folks if you have more questions. Thanks so much for watching.
Do you see, is there something like intermission slides? See that?
Thank you for your specific production. Our community is almost sliding back through this. When leaders talking about this is just for only and now we will slide your staff and centralize the teams all as the nights adding some session.
I think it's good.
Yeah, this is real stuff. So thank you. Appreciate that. Thanks for coming.
What's that? Just get those last one. What's that? Too much. Oh, and I want to talk into my training.
Okay, so kind of try.
Yeah, once.
Are they all, years? Are they, sounds like some of them militaries.
That's a good question. Let me ask them. It's in this room and you're
Right? Age center.
okay at 1:30.
Yeah.
Yeah, it might be if this would come. Yeah. Yeah.
Let's see.
It might be that you could do it now. Let me just ask Taylor, okay? 'Cause she's, yeah.
She's your check.
Yes.
Oh, and you have a 5 minute warning. I like that.
Yeah. That's him.
Oh, you're one minute.
Thanks. Did you email your to someone or is it only on there?
I did email it, but I forgot it's one I told that I had to Georgia side.
So you modified it a little bit.
And then I kind of forgot our votes.
Thank you. See you later.